So today I'm talking about some of the new injectable treatments. Some of them are here, some of them are in the near future. I want to talk about gut hormones, what their role is and how they can help in the treatment of diabetes. And the ones that you may have heard about, some of you may even be prescribed these medications, are called the GLP-1 based treatments. But I also want to talk about some treatments where those are combined in a single product with insulin, ones that have actions that mimic both the GLP-1 and another hormone called GIP, and other ones that combine effects of GLP-1 and a hormone called Glucagon that you might have heard of before. So I don't think this will be unfamiliar to many of you. What is type 2 diabetes? Well, there are two basic things to think about. One is the fact that the tissues are resistant to the actions of insulin. So you can't get the glucose from your bloodstream into the tissues of the body as effectively as you should. And then particularly as the disease progresses over time, the pancreas, which makes the insulin, starts to fail. So you've got resistance to insulin and eventually a reduction in insulin secretion. And both of those act to raise blood glucose levels. I think many of you would be familiar with that concept. So what is a hormone? I think that's an important principle. Hormones are signalling molecules, and the thing about hormones is that they're secreted by specialised glands in the body, and they travel through the bloodstream to act at distant sites. So they're kind of chemical messengers, if you like. And the way they work is they dock with a specific structure called a receptor. And in some cases, particularly the hormones I'm going to talk about today, the receptor is on the surface of the cells where they act, and they lock in with that receptor like a lock and key mechanism in order to cause their actions. And they regulate various functions of the body. Now, blood glucose control is an important goal in type 2 diabetes. And the reason it's important is because we now know that it reduces the risk and the progression of some of the complications of diabetes. And what this figure shows in the green is that for some of the complications that are called microvascular complications, that's the kidney damage, nerve damage and eye damage of diabetes, we know that as your HbA1c, is that a familiar term to people? It's a blood test your doctors might do every 3 or 6 months. It gives you an average reading of what your blood glucose is like. As that goes up, your risk of those microvascular complications increases. So often, doctors will be trying to get that number below 7 or maybe even a little bit tighter than that because we know that that reduces those complications. There is some effect on what's called the macrovascular complications, your heart attacks, strokes, risk of amputation, but it's not quite as prominent. There are other factors there like blood pressure control, control of cholesterol that are probably more important. But control of blood glucose is very important for those microvascular complications. And what's a gastroenterologist like me doing talking about an endocrine disease like diabetes? Well, I think by the end of the talk, you'll be satisfied that the gut is very important in controlling blood glucose responses, particularly after meals. So if you think about it, you eat a meal, it goes into your stomach. The stomach very carefully regulates how quickly that meal empties, and that affects how quickly the carbohydrates are absorbed. Once the nutrients empty into the small intestine, they set off the secretion of various hormones from the intestine itself, and they help secrete insulin. They feed back to slow the rate that the stomach empties, and they also switch off your desire to eat. So you can see that the function of the gut is really critically important to what will happen to blood glucose after meals. And if you've got any doubts about that, it's worth looking at just how dramatically effective weight loss surgery is for controlling type 2 diabetes. You might have heard of an operation called gastric bypass, and it's shown in that diagram. What happens here is that the food only can access a small remnant of the top part of the stomach, and instead it goes fairly quickly into a bit of small intestine. And it's a bit of small intestine that's a bit further downstream than it would normally enter into. And why that's important you'll see shortly. But you can see in the figures on the right that if you're looking at HbA1c levels, compared to normal dietary advice, which is the dotted line, the gastric bypass surgery is much more effective at keeping your HbA1c at about 7 over maybe 5 years at least. And it's much more effective with weight loss. You might know about the number called body mass index, which factors in your height and your weight. And you can see how much lower the body mass index is after that surgery compared to usual dietary treatment. So very effective, and it's all dictated by gut function. And one of the factors that makes this operation so effective is because it does change the release of lots of those hormones that come from the small intestine. Don't worry about the details too much here, but you may get a bit less of the hunger hormone ghrelin, which comes from the stomach because you've got less of the stomach exposed, but you get more of the other hormones that stimulate insulin and turn off your appetite. And I'll talk about some of those in a lot more detail. The other thing in the equation, I've talked about blood glucose control, I've talked about body weight, but the other part of the equation is fatty liver. And some of you may be aware of this problem. In a society like ours where overweight is a big problem, fatty liver disease is now surpassing all the other causes of liver disease as a cause of liver failure. And the problem here is that a healthy liver starts to accumulate excess fat in the liver cells. That's called NAFLD, the non-alcoholic fatty liver disease. In some people with that condition, it will go on and cause inflammatory changes and laying down of scar tissue. And that then really becomes a problem, because if that goes too far, when the condition's called cirrhosis, where you've got a scarred, knobbly liver that doesn't do its job properly, that's a big problem for liver failure and a cause of people needing liver transplants and having all sorts of other complications. So fatty liver is very much a part of this equation as well, and one of the targets of new treatments. So I've talked about these gut hormones. Why are they so important? Well, one of the phenomena that I want to tell you about is called the incretin effect. And this was discovered over 50 years ago, and this is the experiment that really highlighted it. In this experiment, what the investigators did was put a tube down the nose and directly through the stomach into the small intestine on that figure on the left. And they gave glucose directly into the small intestine like that. And then on another day, they injected the same amount of glucose into a vein. And they compared what the blood glucose and the insulin levels did. And you can see the blood glucose figure in the middle. The intravenous glucose, your blood glucose goes up far higher than it does if you put the same amount of glucose into the small intestine. And on the right, the insulin responses are much greater when you put the glucose into the small intestine. So the small intestine's doing something to a glucose load which makes it much easier for the body to get rid of and to handle. Now, why would that be? Well, this goes back a little bit further to the turn of the 20th century. And here are two eminent physiologists working in London called Bayliss and Starling. Starling's there on the right doing something to a dog. He looks like a mad professor, doesn't he? These guys discovered that if you got the top part of the small intestine, the duodenum, and you minced it up and then injected it into dogs, it would cause secretion from the pancreas. They didn't know at the time exactly what it was in those extracts from the small intestine, but something was causing this secretory response. So that was a big clue. Then you had an involvement from a lot of involvement from Germany here. This man is Werner Creutzfeldt. He's a gastroenterologist but was interested in this idea of gut hormones. And he was really the originator of a lot of further development in this concept. He worked out that these extracts from the duodenum probably contain some incretin hormones, and incretin hormones are hormones that are released after meals due to food stimulation, and they stimulate insulin secretion. And he was the originator of the stimulator of a lot of eminent researchers in this field, some of whom I'll tell you further about. So now we know a little bit more about some of these hormones that come from the small intestine. And one of them is called glucose-dependent insulinotropic polypeptide. What a mouthful, so we'll just call it GIP. And the cells that make the GIP are mostly high up in the small intestine, in the bit called the duodenum, which the food contacts pretty quickly after it leaves the stomach. So this was the first identified incretin hormone in about 1970, and here's the experiment, and what it shows is that if you inject glucose, which is the open circles, you can see on the left the blood glucose goes up quite a lot. But if you mix some of this GIP with that glucose that you've injected, there's a much lower blood glucose response. And on the right, that shows the insulin response. The black circles are much higher up than the white circles. That shows that GIP was stimulating additional secretion of insulin. So very important, potentially very useful for diabetes treatment. Then it was determined that the GIP didn't seem to be the only thing that was doing this. There was another hormone called glucagon-like peptide 1, or we'll call it GLP-1. And the cells that produce that predominantly are a bit lower down in the gut. They're further down the small intestine, and they're also in the colon or large intestine. And these are a very important hormone as well. And this hormone was isolated and investigated particularly by these two researchers, both of whom have extensive involvements with Adelaide. So Dan Drucker's made a couple of visits here, and Jens Holst has had a growing affiliation with our group. And jointly, they really discovered in their labs that this long hormone called proglucagon is processed in different ways depending on the site. So in the intestine, that hormone is snipped into different segments, and one of those is that hormone GLP-1. And in the pancreas, it's snipped in a different way, and glucagon is one of the products that results from that hormone. So the 1980s were a very fruitful time in discovering this GLP-1. Now, what use was GLP-1? The man pictured here was a researcher who studied under Werner Creutzfeldt and is now a world figure in this area in his own right, Michael Nauk. And Michael's made a few visits to Adelaide as well. And Michael's work in the early 90s looked at what happened if you got this GLP-1 hormone and you gave it through a continuous intravenous infusion to people with diabetes. And what you can see in the figure is that people came into the lab, their blood glucose was a bit on the high side, about 12.5. And he infused either the GLP-1 or a dummy called a placebo, and you can see the difference over 240 minutes of what happens to their blood glucose curves. The people who got the GLP-1, the blood glucose goes right down to normal levels, about 5 or 6. Whereas the people who get the placebo really have minimal effect. So this looks like a really effective treatment to lower blood glucose in type 2 diabetes. And we now know that GLP-1 has got a few key actions. On the right, that stimulation of insulin is one of the actions, acting on those, what we call the islets in the pancreas, where insulin comes from. But it does a few other things. It slows the emptying of food from the stomach, and that could be good because it would mean that you get delayed absorption of carbohydrates. Down the bottom, it also reduces the output of glucose from your liver, which is an important way of helping control your blood glucose. Up the top, it also acts on the brain. It lowers your appetite, so you tend to eat less. It also seems to have some protective properties for the brain. It might be useful in some diseases like Parkinson's or dementia. And it's also got some protective qualities in the heart. So this looks like it could be a really useful treatment for diabetes. Now, we've got these two hormones. We've got GIP and we've got GLP-1. And I've shown you the incretin effect, how glucose delivered into the gut is much more effective at keeping glucose under control than intravenously. We know in diabetes that effect is reduced. People with diabetes do still keep secreting normal levels of GIP, but unfortunately, it doesn't seem to work as well. People with diabetes also seem to secrete normal levels of GLP-1, and in contrast, GLP-1 still seems to do a pretty good job in people with type 2 diabetes, like I showed you in that figure with Michael Now. So if you were going to develop a drug out of this, you'd probably focus your efforts on GLP-1. But there is a problem here, and that hormone GLP-1, when it's in your circulation, it gets inactivated in about a minute or two because there's an enzyme widespread throughout the body called DPP4, and that breaks down that GLP-1 very quickly and inactivates it. And you might have heard of drugs that we now have called DPP4 inhibitors, and I've listed some of them down there, things like sitagliptin. Some of you might even have been prescribed some of those medicines. They block that DPP4, and they mean that the GLP-1 and the GIP hang around longer. So that's one way of treating diabetes and stimulating the effect of these hormones. But it might be better if you could give some form of GLP-1 that lasted longer, because you can't have people going around with a continuous infusion. It's not very easy to manage. So this is a really interesting story about a lizard. And the lizard is the Gila monster, and it's native to New Mexico and Arizona. And the lizard, in its venom, has a number of different peptides, and one of those peptides that was isolated was called exendin 4. And it was in the early 90s that was found. And exendin 4 has got some similarities to the structure of GLP-1. Isn't that remarkable? But unlike GLP-1, it doesn't tend to break down with DPP4. So this could be a really useful thing to know about. And this guy on the left called John Eng, he was working at the Bronx VA Medical Center in New York, and he was onto this and thought this could be really useful as a treatment for diabetes. And do you know what? He thought this should be patented, but his bosses at the VA hospital weren't interested. They were only interested in disorders that specifically applied to veterans. So they said, do what you like with it. So he went and took out a patent, and no one in any of the pharmaceutical companies was interested at all until this guy in the middle, Andrew Young. Andrew is a New Zealander, but he works for a company in San Diego. He was at a meeting and he looked over someone else's shoulder at this poster that was being presented about exendin 4 and said, this could be something useful. So he had discussions with John Eng and actually bought the patent for his company, and then had to try and interest one of the bigger companies in it. And eventually Lilly was the company that took this on, and that is the origin of what's now called Byetta. Has anyone heard of Byetta? So Byetta is an available injectable treatment based on this exendin 4 from the Gila monster venom, and it's a treatment we now have for type 2 diabetes. As a sideline, there's work going on in Adelaide with this guy, Frank Grutzner, who works in our university. Believe it or not, echidnas and platypuses, who are monotremes, they also have GLP-1-like peptides in their venom. And Frank's isolating various versions of these and testing them to see which ones might have useful properties for diabetes. And he's got some commercial funding to try and help develop that into an idea. So this kind of thing is still going on, believe it or not. But we now have a number of these mimickers of GLP-1. Some of them are similar to that venom peptide exendin 4, and some of them are more direct copies of human GLP-1. And the other difference between them is that some are short-acting, they don't last many hours, you have to inject them once or twice a day, and others are long-acting. You might only have to inject them once a week, or maybe even less. And that's a difference, of course, of convenience, but it might affect a little bit how they work. So we've now got actually quite a number of these GLP-1 based drugs that are now on the market as injectable treatments. And I've put some of them up there and circled in red the ones that are approved in Australia. So we've got a number of options in that regard, and a few of you might be familiar with some of these. What are they good for in diabetes? Well, we know from the clinical studies going up to a year that they do lower that HbA1c. It's usually between about 1 and 1.5%. They lower the fasting blood glucose by 1 or 2. And an advantage of these compared to something like insulin is that they help you lose a little bit of weight. It's not a lot, but it's 2 or 3 kilograms. And unlike insulin, they have a very low risk of causing hypoglycemia because they only stimulate insulin when your blood glucose is elevated. So that's a really useful drug. Now, one of the problems with drugs in diabetes is that over 10 years ago, it was found that one of the drugs called rosiglitazone, unexpectedly, once it was being marketed, was found to cause excess cardiovascular deaths. And this caused a huge stir. And from 2008, the FDA, which is the regulatory authority for drugs in the US, started to demand that any new diabetes treatment had to have huge trials done to make sure they were safe in people who had cardiovascular disease. And in fact, these have really been quite useful because they've shown not only are they safe, but they actually reduce the risk of cardiovascular disease. So this has been shown for a lot of these GLP-1 based compounds in big trials involving thousands of people. So yet another advantage of this drug class. But there are some downsides. One of the problems is that they have a rate of gastrointestinal side effects, such as nausea, diarrhea, and things like that. And it's about 40% of people will get that side effect. Usually it will melt away in about the first 12 weeks, and it's less if you slowly increase the dose, but that's a problem. And the second problem is the figure on the right shows what happens over time when you look at who's still filling their prescription from pharmacies. And you can see that at about 12 months, only about half the people still seem to be taking these sort of medications. And we don't really know all the reasons for that. But clearly, for some reason, people aren't persisting with them at high rates. So how could we improve these treatments? Well, you could do something to make the more effective by changing how they're administered. Or you could combine them with a long-acting insulin so you get the best of both worlds. Or you could target not just the GLP-1 receptors, but add in some extra activity, perhaps involving GIP or glucagon. And I'll tell you a little bit about these because some of these treatments are either here or on the imminent horizon. So this is a study that we're doing with Michael Nauk. And one of the things that we've observed, I've showed you that picture earlier on where Michael in the 90s infused GLP-1 intravenously and it normalised blood glucose in people with type 2 diabetes. In the clinical use, we inject things not intravenously, but into the subcutaneous tissue. And is there a difference between how effective that drug is subcutaneously compared to intravenously? So in conjunction with Michael, we're doing a study where people with type 2 diabetes who are on long-acting insulin come into the lab, and they come in on 2 days where their blood glucose has been allowed to come up a bit, and we're going to give them intravenous GLP-1 on one day and subcutaneous on another, and compare both their blood glucose responses and what sort of side effects they get. Because we're very interested to know if it's the subcutaneous injection that is part of the reason why these treatments might not work as well as they could and might have more side effects than they otherwise might. So that's ongoing work, or work about to start, in fact. I mentioned the combination of GLP-1 active drugs with insulin. They're called fixed ratio combinations. These aren't available in Australia, but they are in USA and Europe. So there's a couple of those combinations available. And they seem to be useful in some people when you've been on a long-acting insulin and it's not doing the job, or you've been on one of those GLP-1 drugs and that's not doing the job. And the advantage of them is shown here. What happened in this study was that people who were on long-acting insulin and metformin were enrolled in this study. And you can see the HbA1c over time on the left. And on the purple curve, they've had their dose of long-acting insulin adjusted to try and improve their blood glucose. And in the blue curve, they've been treated with this combination product of a GLP-1 drug plus insulin. And you can see that that combination is better at lowering HbA1c. They got below 7% on average. And on the right, it's also better at keeping your weight under control. So with the insulin, the weight tended to go up a bit, which is a complication of insulin. But when you mix it with a GLP-1 drug, they didn't tend to put on weight. They even maybe just slightly lost a little bit. Now, I mentioned that GLP-1 is not the only incretin hormone. The other one is called GIP, and it kind of got disregarded because it doesn't seem to work very well in people with diabetes. But should it in fact be shelved? It's been neglected, but possibly it might be useful. So in the red there, one of the reasons why, apart from its poor activity in diabetes, was that it might increase the amount of fat or adipose tissue that you build up. So that would be a bad thing. I've put a dotted line around the pancreas because it doesn't stimulate insulin for the pancreas quite as well in type 2 diabetes as it does in healthy people. But maybe with better blood glucose control, you might regain your responsiveness to GIP. So it might actually have some use. And the other properties that are useful for GIP are that it is protective of bone and it's protective of the brain. So it's got some useful properties. So can you restore the action of GIP in people with type 2 diabetes? Well, this is another study we're running at the moment, and this is in collaboration with Jens Holst from Denmark there, one of the father figures in this area. And what we're doing here is that we're enrolling people with diabetes who are on diet or metformin alone, and we're looking for people who are moderately well controlled but not quite at target, HbA1c of between 7 and 8. And what we're doing is we're getting them into the lab at the start and measuring their responsiveness to GIP using a GIP blocker. And then we're giving them 12 weeks of treatment with one of those DPP-4 inhibitors, sitagliptin, to try and improve their blood glucose control, and then studying again at the end of that time whether they can regain their responsiveness to GIP. So that's some more work that's about to start in our lab at the moment. Now, what you can do is you can develop a treatment that stimulates GLP-1 receptors, so it's got those benefits, but it also works on the GIP receptor. So it's called a dual agonist. It acts on both receptors. And we've got one of these treatments called tirzepatide, which is now in large clinical trials and will probably be approved in the US for treatment within the next year or two, and I guess will be finding its way to Australia at some point. And this really shows you some of the data that we've got about how effective tirzepatide is about improving HbA1c. Now, the complicated code LY blah, 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 blah is the sort of code name for the drug when it's in development, but that's just different doses of tirzepatide. And what this figure shows that as the dose that people were given increased, their ability to lower their HbA1c over time became more and more effective. In the red, you've got one of the standard GLP-1 drugs, dulaglutide, and you can see that the highest doses of tirzepatide can achieve lower HbA1c responses than that red drug. So it looks as if it might be promising. And same thing for body weight. The people on the higher doses, in the darker blues, lost substantially more weight than the people on the red GLP-1 based drug. So this looks as if it might be better. And also, it does seem to improve some of the markers of fatty liver disease. I talked about that as being an important goal. The compounds in the blue lower some of these markers more than the standard GLP-1 in red does. So it could be good for fatty liver disease. So where to now with this drug? Well, we need to know more about its effects with prolonged use. We need to know whether it will be good, in fact, for bones, because it might have that advantage of GIP receptor stimulation on bones, and we need to know more about its cardiovascular outcomes, and there's big trials going on for that. It does, unfortunately, have the side effects that you'd expect with any drug that stimulates the GLP-1 system. It's got the nausea and vomiting and diarrhoea, but again, hopefully they'll be not too severe and fairly short-lived and melt away over time. So more to find out on that front. There's this big trial now underway about those cardiovascular outcomes. Just to give you an idea of the scale of these trials, thousands of people need to be enrolled, and the one for tirzepatide is enrolling 12,500 patients. These trials all cost about $1 or $2 billion to run, and who knows what the cost of the one for tirzepatide is going to be. So you can understand why there are such high costs when these drugs finally come to market, why they are priced so expensively, and why the federal government might be a little bit loath to put them on the Medicare system. But these are all things that are yet to come. Last of all, glucagon. Glucagon, again, is it good or bad? You might think glucagon would be bad because if you give glucagon, it's a treatment if you have hypoglycemia. It puts your blood glucose up. So surely that's a bad thing to do. But it's also got these positive effects. It stimulates insulin secretion from the pancreas. It slows down emptying from the stomach, and we've said that that can be a good thing because it delays carbohydrate absorption. And it's also got effects on the brain. It can reduce appetite, and it actually reduces energy expenditure, increases energy expenditure, and that would be good for weight loss. So maybe this is a good target to aim for. One of the combination drugs that targets GLP-1 and glucagon together is this one called cotadutide. It's still in clinical trials, but this is an example showing how the blood glucose is lowered after a meal by test doses of cotadutide over about 50 days. And this shows what the drug did to fatty liver. This is an MRI scan of the liver, and how dark the liver or how light the liver is, shown in the white arrow, tells you how much fat is in there. And with the placebo down the bottom, there wasn't any change in how bright the liver is, but up the top, you can see that the liver from baseline to day 41, it's got darker. And that means that the amount of fat in the liver has reduced. So this could be a good drug for reducing that fat accumulation that we know can cause long-term liver damage. So finishing up, just a very brief bit about our group. We're in the Adelaide Biomedical Precinct. Our building is the second one from the right there. You can see where we are at the convention centre, and then going down you've got UniSA, you've got our University of Adelaide building, SAMRI 2's going up, then you've got SAMRI, the cheese grater, followed by the Royal Adelaide Hospital. And that's what our building called the AHMS building looks like on North Terrace there. I need to acknowledge all the bodies that have supported our work in this area, including particularly Diabetes SA, and we love to come and talk at events like this, and we're very grateful for the contribution of people from the community with diabetes who have participated in our studies. And I particularly want to draw your attention to Jackie and Michelle. You'll find them manning a stall out in the foyer. I think they've slipped in at the back here. They look friendly, don't they? Here they are feeding one of our volunteers at the end of a study, and they're the contact details for Jackie and Michelle. So there's something mildly amusing to finish the talk off. I hope I haven't been that annoying. And I'll just leave their details up.